Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to Med School. Topic for this video is hypercalcemia. Calcium is measured as total calcium which includes protein bound as well as ionic calcium and ionic calcium separately. Moreover, calcium is measured in two units, milligram per deciliter and millimole per liter. Also, there are three different categories of hypercalcemia according to severity. So remembering values of serum calcium level in two different forms in two different units is little bit confusing. I tried to make it easy to remember with the visuals. Mild hypercalcemia is when serum total calcium level is between 10.5 to 11.9 milligram per deciliter or 2.5 to 2.9 millimole per liter, or ionic calcium level between 5.6 to 7.9 milligram per deciliter or 1.4 to 1.9 millimole per liter. Moderate hypercalcemia is defined as serum total calcium level between 12 to 13.9 milligram per deciliter or 3 to 3.4 millimole per liter, or ionic calcium level from 8 to 9.9 milligram per deciliter or 2 to 2.4 millimole per liter. Severe hypercalcemia is also known as hypercalcemic crisis. It is defined as serum total calcium level from 14 to 16 mg per deciliter or 3.5 to 4 millimole per liter, or ionic calcium level between 10 to 12 mg per deciliter or 2.5 to 3 millimole per liter. You must be thinking, what about serum calcium level above these upper limits of severe hypercalcemia? Survival is very unlikely above this level and death ensues. If you still feel confused, you can remember values in any one unit and values can be changed to other unit using this formula. Let's first understand calcium metabolism. When calcium level falls, it induces parathyroid hormone release from parathyroid gland, which increases absorption of calcium through intestine, increases bone resorption and mobilizes calcium from bones to blood, and decreases excretion of calcium through kidneys. All these processes leads to increase in calcium level. When serum calcium level rises, this induces secretion of calcitonin from thyroid gland. Calcitonin causes decreased absorption of calcium through intestine, increased deposition of calcium into bones, and increased excretion of calcium through kidneys. All these processes leads to fall in serum calcium level. There is one more player in calcium metabolism, which is vitamin D. As we saw, PTH works only toward increasing calcium level and calcitonin works only toward decreasing calcium level. Whereas vitamin D causes increased absorption of calcium through intestine, decreased excretion of calcium through kidneys, and enhances calcium deposition into bones. 99% of body calcium is stored in bones. So, hypercalcemia is most commonly caused by increased calcium mobilization from bones in malignancies, hyperparathyroidism, hypophosphatemia, immobilization, vitamin A toxicity, renal failure, and hyperthyroidism. Out of these, hyperparathyroidism and malignancies are the most common causes. In malignancy also, most cases are due to PTH related peptide secretion rather than bone metastasis. Hypercalcemia can also occur due to increased absorption through intestine in familial infantile hypercalcemia, hypervitaminosis D, hyperparathyroidism, etc. Decreased calcium excretion leading to hypercalcemia occurs in familial hypocalciuric hypercalcemia, thiazide diuretic use, etc. Increased vitamin D intake or ectopic production of vitamin D as in granulomatous diseases like sarcoidosis, etc. can cause hypercalcemia. Parathyroid adenoma, ectopic PTH secretion from tumors, multiple endocrine neoplasia 1 and 2A leads to hyperparathyroidism and hypercalcemia. The mnemonic stones, Bones, abdominal moans, and psychic groans describe the constellation of symptoms and signs of hypercalcemia. Features related to renal system include polyuria, dehydration, renal stones, and renal failure. Clinical features related to bones include osteopenia, bony pain, pathological fractures, etc. Clinical features related to gastrointestinal system include constipation, nausea, vomiting, gastric ulcer, pancreatitis, etc. Clinical features related to central nervous system include lethargy, weakness, confusion, and even coma. Hypercalcemia can also cause arrhythmia and heart failure. As with any other electrolyte abnormalities, history is the most important tool to ascertain underlying cause. Serum calcium level, both total and ionic, other electrolyte level like serum phosphorus, magnesium, sodium and potassium, serum parathyroid hormone level, serum vitamin D3 level can help to reach at the diagnosis. Radiological investigations like X-ray, CT scan, MRI, PET scan are often needed to confirm the presence and evaluate the extent of spread of malignancy. Serum parathyroid hormone related peptide level can be done in patient of malignancy with hypercalcemia but no bony metastasis. Most common ECG feature of hypercalcemia is shortening of QT interval. Other features include prolongation of PR interval and QRS complex, J wave at the end of QRS, and ST elevation mimicking acute myocardial infarction. But these features are non-specific. First line treatment of hypercalcemia is volume expansion. Let's understand why. Hypercalcemia leads to symptoms like nausea, vomiting, polyuria, and altered mental status. All these features leads to dehydration. Dehydration induces sodium reabsorption from kidneys. In thick ascending limb of Henle, calcium is also reabsorbed along with sodium, which further aggravates hypercalcemia. To break this vicious cycle, first line treatment of hypercalcemia is volume correction with IV normal saline. This will reduce sodium and calcium reabsorption from thick ascending limb of Henle. Loop diuretic can be added to enhance renal calcium excretion. Bisphosphonate reduces osteoclast activities and reduces hypercalcemia. IV bisphosphonate available are pamidronate and etidronate, while rezidronate and alendronate can be given in oral formulation. Other treatment options in refractory cases include denosumab, which is an monoclonal antibody against rank ligand on osteoclast. They inhibit osteoclastic activity and reduces mobilization of calcium from bones into blood. Calcitonin can be given subcutaneously or intramuscularly, but it is effective for initial few weeks only, after which it loses effectiveness. Mithramycin is also an osteoclast inhibitor, but it has significant hepatic, renal and marrow-toxicity. Prednisolone can be used in cases of vitamin D toxicity. Moderate to severe hypercalcemia not responding to any other therapy needs either peritoneal or hemodialysis with calcium-free or low calcium dialysate. Surgical care of malignancy often removes source of parathyroid hormone related peptide and reduces serum calcium level. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.